We have covered mainly the metacarpals now, that is the fractures of the head, the neck, the shaft, as well as the base, and especially the fractures of the base of the first metacarpal, that is with intra-articular extension including both the Rolando and Bennett, and then the only involving the base of the first metacarpal. Now from metacarpals we'll move on to the phalanges. As you know, the thumb has only the proximal and distal phalanx, while all other four fingers have proximal, middle and distal phalanx. In this section, we will be discussing only the proximal and the middle phalanx fractures. We will be discussing fractures of the proximal and middle phalanx, undisplaced and displaced fractures, and childhood phalangeal fractures and how to treat them accordingly. Usually, the phalanx fractures may in various ways. This could be simple as a transverse fracture of the shaft, this could be a spiral fracture of the shaft. If you see this is an oblique fracture, this is probably an oblique fracture. This could simply be a transverse fracture over here as well. It could be a comminuted fracture in which there is a lot of pieces of the shaft of the proximal or middle phalanx. There could be an avulsion of the small fragment in which actually the tendon injuries is also present and the small fragment has actually avulsed out as well. So that means there is not associated reduction in range of motion, plus there is also intra-articular extension as well. There could be a metaphyseal fracture at the base of the proximal phalanx, especially in the case of the children, or there could be distal condyle fractures which could be seen over here, and there will be very small fragments could be present in which there may be slightly displaced or totally undisplaced. Now, the treatment is usually conservative. Very rarely you require a surgery in form of a KOIs. For all undisplaced fractures, they are treated by functional splintage, that is called as buddy or neighbor strapping. That, for example, if I have a fracture of the proximal phalanx of the index finger, and let's suppose it's a mid-shaft transverse fracture and it's undisplaced, all I can do is simply apply a buddy tape so that my index finger is actually supported by my middle finger in such a way so that the fracture remains at the place and remains undisplaced. So usually the most common technique in case of phalangeal fracture is always the buddy taping or strapping. Movements are encouraged straight away. If you go up in the market, there is splints are called as the buddy splints, which are readily available. They can also be worn, and their movement can be carried out in that. So otherwise, there's different methods by which we can do the buddy strapping. Splintage is retained for 3 to 4 weeks, and the check position of the X-rays are usually done at after 4 weeks, and later on, full exercise and range of motion is actually started. If it's displaced, now the displacement could be either volar, or it could be dorsal, or it could be angulation only as well. It must be reduced and immobilized and check for rotational correction. So what is important in this case is actually if there is no rotational abnormality. Treatment depends upon the fracture pattern. For example, if it's a basal fracture with an extension, it usually needs a manipulation and held with the dorsal blocking splint. If the fracture is, this is the metacarpal, and if it's involving the base, that is this area with the extending into the dorsal surface, then probably you need this kind of a splint. But if it's extending into volarly, then you probably need a volar splint. With metacarpal joint is usually held at 90 degrees. This is the rule. This is the functional position of the hand in which the metacarpal phalangeal joint is at 90 degree of flexion, where usually the interphalangeal joints are in extension. Now coming to the displaced and angulated basal fractures. They are usually manipulated with a pencil between the digits. That can be a technique, an old technique can be used to actually do it, and then held with the navel strapping, which pulls the injured finger towards the next one, and it also provides the support. Now if there are spiral fractures, they can be held with the derotation taping next to the next digit, using tension the tape so that to unwind the fracture and help to heal it properly. Now if there is displaced fracture, for example, this is a diagram this is an X-ray which is showing actually an oblique long oblique fracture of the usually the neck involving a shaft of the proximal phalanx of the little finger. As you can appreciate, this is a long fracture and it's actually extending right up till the base of the through whole of the shaft and up to the base of the proximal phalanx. So this was a large segment. This could have easily been this can be managed in buddy taping, but if you suspect that it's going to get displaced and later on get non-union, we can go for K wiring as well. And then this, you can appreciate there are 3 K wires. Actually use the 2 to derotate this so that this does not rotates on its own, and 1 is actually used to kind of create a lag effect. If it's simply transverse fracture, they can be held in a gutter splint if involving the fourth metacarpal, or simply buddy taping can also be, a neighbor splint can be used as well. But if there is no reduction, for example, this was a comminuted fracture, you tried to reduce it, but still the fracture fragments are actually not reducing in and they're extending into the joint, then we can go for plate and screw fixation, and mini micro plates are available which are available so that this phalanx fractures can be actually reduced and plated. Or simply the K wire, as I can see that I just showed you in the previous X-ray, that K wires can be simply more than enough, especially with the phalanx fractures as well. Or if this is a kind of a spiral fracture or oblique fracture, we can apply a small single lag screw as well, and then give the buddy taping or neighbor strapping so that the patient remains splinted for a few weeks as well as fixed as well percutaneously. If it's highly comminuted, external fixation is an option, but usually rarely it is required. Now coming to the childhood phalangeal fractures, they are very rare and shaft may be usually break, but close reduction, early mobilization is more than enough. If the growth plate is damaged, perfect reduction and temporary K-wire fixation is needed. Sometimes if we suspect there is a growth plate injury, if there is a distal condylar fracture, which is more common in children, if it's a very small fragment, then all you need to do is to just apply the buddy splint. If it's a very large fragment, then either you can apply K-wire or simply a small screw can also be applied to hold the condyle of the distal phalanx or proximal and middle phalanx in place. Now we have just gone through the proximal and middle phalangeal fractures in this section. Usually, as with other metacarpal fractures, the most commonly method used to treat these fractures is actually a conservative method called as buddy taping and neighbor strapping. The side finger can be used to provide support and keep the non-displaced fractures in its position. But if it gets displaced, it can be reduced under local anesthesia and we can apply K-wires. Most of the fractures will require reduction. K-wire is more than enough in form of 2 or 3 K-wires. But nowadays with highly comminuted fractures, there are mini plates which are available for phalangeal open reduction internal fixation, as well as we can go for external fixator of the phalanx, which is also available but rarely done. Thank you very much. Keep watching sqadia.com.